Okay, now when we start talking about the specific injuries themselves, we'll start with looking at subdural hematomas. If you recall from your anatomy and physiology or from your pathophysiology, remember a subdural hematoma is when we have blood that's below the dura space. Usually subdural hematomas are venous in nature, and they tend to have a fairly high mortality rate. Now, when we talk about subdurals, we break them down depending on what class they are, and if we break them down depending on how quickly they present themselves. If the patient takes a shot to the head and the patient has neurologic symptoms within the first 24 hours, we would call that an acute subdural. If the patient waits 2 days to 10 days before they have symptomology, we call that a subacute subdural. And finally, if the patient presents with symptoms of neurologic complications, but it's been greater than 2 weeks since they took a shot to the head, we would call that a chronic subdural. Now, when we look here at this CT, this is a good example of a subdural. You can see that there is a subdural there on the left upper part of the CT. And the thing that characterizes a subdural is the fact that there's not a clear line of delineation between what is bleeding and what is brain. When you look at that bleed and you look at the brain, you see that the edge is very jagged. It's not a very sharp, clear edge. That's classic of a subdural. The other thing that you see with this subdural is it does not have very sharp, pointy edges like a epidural bleed does. So this is a great example of a subdural hematoma. Here are a couple more pictures of subdurals. When we look at these subdurals, you can see obviously that the subdural is on the right side of the skull there, assuming that the front of the skull is the part of the skull that is facing up towards the top of the screen. And when we look at this subdural, this is a very ominous subdural. When you look at the subdural itself, it doesn't look like it's so big, but the thing that's very impressive about the subdural is the amount of shift. You can see that when we look at the midline of the CT, there's a huge amount of shifting of brain tissue over. And for every millimeter that the brain shifts over, that significantly increases mortality. So this patient's got a massive shift. This patient is probably going to die from this subdural unless it's relieved very, very quickly. Here is a example of an older subdural. This subdural right here would be a subacute type subdural. You can see that it's got a more granulated appearance to it. It doesn't appear bright white. There's more of a salt and peppery kind of appearance, and that tells us that bleed is a little bit older. Next, when we look at this CT right here, you see that this would be an example of a chronic subdural. The subdural here is on the bottom of the CT or on the posterior part of the skull. This patient has a very granulated bleed. It's a fairly large subdural, but it's very granulated, which means that a lot of the protein and a lot of the fluid has been reabsorbed. This is a good example of an old subdural hematoma. Okay, when we talk about subdurals, we see them a lot in elderly people. One of the reasons we see them a lot in elderly people is because their big propensity for falling. And remember, in elderly people, a lot of times they don't present emergently with the subdural because, remember, as you get older, there's a little bit of atrophy of your brain, and so your brain is a little bit smaller in relation to your skull. And so as blood collects in that potential space or in that actual space, there's got to be a fair amount of blood collected before we actually start to push on the brain. So a lot of times your elderly people, the way they present is with a subacute or a chronic subdural. In contrast, in really young people, especially the younger you are, like small kids, remember that their brain is very tightly crammed into their skull, so they have essentially no room, and so even a small subdural will typically present very, very rapidly with very dramatic signs. When we talk about pediatric patients with subdurals, one of the most common age groups for subdurals is actually kids less than 18 months. And remember that in most kids less than 18 months, their fontanelle has not completely closed. So if they've got a subdural, that may present itself actually as a bulging of their fontanelle. One quick note about pediatric head injuries in kids who are small enough that their fontanelle has not closed yet. Remember that those children are much more likely to die from bleeding to death from a head injury like a subdural than to die from herniating, because they've got this space that's available for blood to escape out of. Okay, when we talk about epidural bleeds, remember epidural bleeds are bleeding between the skull and the dura mater. Remember we said again that epidural bleeds are typically arterial. Not always, but most of the time epidural bleeds are arterial. Remember we said with epidural bleeds we will see a very clear line of demarcation, a very sharp edge to them, and we will also see very pointy edges. We see that lens type shape or that lenticular type shape. And when we talk about epidural bleeds, probably the most common reason we would get an epidural bleed is because we take a shot to the side of the head, which lacerates the middle meningeal artery. So those two things kind of go hand in hand, damage to the middle meningeal artery and epidural bleeds. Here are a couple of good examples of epidural bleeds. The one up above us is a fairly small epidural bleed. You see that there's relatively small shifting. So as long as this is evacuated fairly quickly, this patient will do fine. When you look at the epidurals off to our side there, you see that they're much more dramatic, they're much larger, and you also see that this series of CT film shows a significant amount of shift, so this obviously would be a much more much higher mortality epidural bleed. Okay, now when we talk about epidural bleeds, it's worth just mentioning real quick the classic presentation. Remember, with an epidural bleed, the classic way that these people present is they take a shot to the head that knocks them out. They're out cold. After they're out cold for a period of time, they actually wake up and they actually have a phase where they actually have some level of consciousness return, and it can be all the way back up to alert and oriented times 4. Then, as that epidural bleed is collecting in size, we have a mass effect of the brain, and as that mass effect is pushing the brain over, the patient has a second level of consciousness decrease. So again, with epidural bleeds, the classic thing is they take a shot to the head, knocks them out cold, they wake up, then they have a second drop in their level of consciousness as the mass effect shifts their brain over and they start to herniate. Now, when we talk about epidural bleeds, we break them down into two phases, acute and subacute. Acute bleeds are usually arterial bleeds, and they usually occur we see symptoms within the first couple hours, whereas a subacute bleed is typically a venous bleed, and this takes a lot longer to show up, so this is a much slower type bleed than the acute bleed. Okay, when we talk about subarachnoid bleeds, there's a couple of good reasons why we would get a subarachnoid bleed. So when we talk about subarachnoid bleeds, the most common reason somebody gets a subarachnoid bleed is actually because of trauma. So subarachnoid bleeds, most common reason we see subarachnoid bleeds is trauma to the head. The second most common reason why we get subarachnoid bleeds is actually because of a rupture of an aneurysm in the circle of Willis or a baryaneurysm rupture. So the big thing to remember about subarachnoids is that the traumatic subarachnoid bleeds we're going to treat just like we treat every other kind of head injury. The whole focus is on maintaining the ICP, maintain the CPP, blah, 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 blah. When we talk about our medical subarachnoid bleeds, our arachnoid bleeds that occur from ruptures of aneurysms, this is the one bleed that we manage completely different than all the rest of our head injury management. With subarachnoid bleeds of a medical nature, most of the time what happens is the patient has a rupture of an aneurysm and they quickly lose consciousness and quickly die. Most medical subarachnoid bleeds are fatal within a very, very short period of time. The classic presentation of the subarachnoid bleed is the patient who either shows up in the ED complaining of the worst headache of their life and they never go home because they die in the ED, or the patient who's just walking down the street minding their own business and boom, they just drop dead. So subarachnoid bleeds tend to be very dramatic. Now, there are a subset of patients who will have an initial subarachnoid bleed because of a rupture, but that rupture will be self-limiting. But because there's now a collection of blood in the head, there's an increase in ICP, and that increase in ICP creates a high potential for that aneurysm to rupture a second time. If we look at patients who get a subarachnoid bleed because of a second rupture, the mortality rate is nearly 100%. So, unlike all of our other head injury patients, or all of our other neuro patients, I should say, with subarachnoids, our focus is exactly the opposite. Instead of maintaining CPP, instead of increasing the blood pressure, with subarachnoid bleeds of a medical nature, we actually want to bring the blood pressure down. We want to decrease the amount of perfusion to that circle of Willis. Think of it almost as like the way that we would treat a AAA. We all know that if somebody's got a AAA, we want to decrease their heart rate, we want to decrease their contractility, we want to decrease their blood pressure so their aorta doesn't aneurysm any quicker than we would prefer it does. With a subarachnoid bleed, it's the same thing. We want to decrease the chance that they're going to have a rupture again, so we bring down the heart rate, we bring down the blood pressure. A lot of times we'll do this by using vasoconstricting drugs like, vasodilating drugs like Cardine or Nipride or things like that. Now, the other thing about a subarachnoid that you need to know is how to look for it. Subarachnoids tend to be a little more difficult to find than some of our other bleeds. The classic thing we look for with a subarachnoid bleed is actually something called a starfish pattern. And if you look at the head above me, if you look at the CT above me, you'll notice that there's 5 lines that come together in the circle in the middle. That almost looks like a star or a starfish. That's the classic thing that we see on a CT of a subarachnoid hemorrhage. When we look here at the CT above me, again, you see all 5 points coming together in the middle. This is another starfish, although it's a much more difficult to see, much harder to identify starfish, but there is still 5 points that come together. Again, a classic subarachnoid. And when you look at the picture off to my side there, you'll notice that on the as you're looking at the screen off to the right, about mid-screen, mid-picture, you see a big, huge blob. Well, if you look at the blood vessels in the middle of the screen that make almost a diamond shape, that is the circle of Willis. And then if you go off and you look at that blob off to the side, that blue-colored blob, that is a huge, huge aneurysm. So that gives you an idea of how big those aneurysms can get. And if that patient's aneurysm had ruptured, then it would have surely instantaneously killed that patient. So those aneurysms can be quite large. And again, our whole focus with a medical subarachnoid bleed is to prevent rupture by decreasing the ICP, decreasing the patient's blood pressure, and keeping their heart rate down. And usually the target that most neurosurgeons use is a systolic blood pressure of 140 or less. So they usually would not like the blood pressure to be any more than 140. Okay, again, when we talk about the presentation, the big thing that these patients present with is what they describe as the worst headache of their life. A lot of times these patients, again, will deteriorate very rapidly and will die before they'll ever even leave the emergency room. The other thing that you may see that is commonly misdiagnosed or missed, because it presents very similar to subarachnoid bleeds, is meningitis. And you can have the converse as well. You can have a subarachnoid that's missed because of the fact the patient has, because the practitioners think the patient has meningitis. So both of these cause blood to accumulate in the meninges, and because of that meningeal irritation, we're going to see all of those classic symptoms like we talk about in other sections when we talk about meningitis. So again, with our subarachnoid hemorrhages, the patient may complain of like neck pain. They may complain of neurological symptoms that are complicated by the fact that when they tilt their head down it hurts more, or when they draw their legs up it hurts more. So oftentimes subarachnoid bleeds are misdiagnosed as meningitis. Now, one quick note to say about subarachnoid bleeds. Remember that the standard of care for meningitis, when we're diagnosing meningitis, we do that by obtaining a lumbar puncture. And because these two things look so similar, you want to assure that we never do a lumbar puncture in anybody who has a potential subarachnoid until we've actually spun them, looked at their CT, and verified that they do not have a subarachnoid. So the subarachnoid takes precedence over the meningitis. We do the CT first. Once we're sure they don't have a subarachnoid, then the next thing that we would do is an LP to find out if they've got meningitis. Okay, when we talk about intracerebral hematomas, that's when we actually have bleeding in the brain itself. This is usually because of shearing type force. A lot of times it'll happen in the white matter, but it can happen pretty much anywhere in the brain. Some of the more common places where we'll see intracerebral hematomas are places like the front of the brain and the temporal region of the brain. And if you think about it, that makes sense, because that's where we see most people take shots to the head. They either take it in the front of the head or they take it in the side of the head. We can have a single intracerebral hematoma, or we can have multiple intracerebral hematomas. And when we have just a ton of very small intracerebral hematomas, we actually call that diffuse axonal injury. Now, when we talk about an intraventricular hemorrhage is where we have bleeding into the ventricle itself. It usually occurs with really, really massive trauma. It's almost always because of a shearing type force. And these patients have really, really high mortality because when you are normally bleeding in your head, one of the first things your body does to compensate is it pushes CSF down out of your head and collapses your ventricles to make space for the bleed. Well, if the bleed is occurring in the ventricle itself, then obviously the ventricle is not going to be able to collapse. So these patients can have really high spikes in their ICP really, really quickly. When we look at the CT there above us, you can see that that patient actually has both an intracerebral hematoma and also has a intraventricular hemorrhage as well. Okay, when we talk about closed head injuries, just a quick review of a couple of different types of head injuries. When we talk about a mild concussion, remember that a mild concussion is usually because of a rotational type force, like what we would see in a relatively minor impact. And the classic thing that defines a mild concussion is the fact that the patient has a complete reversal of their symptoms and they don't have any persistent problems. Usually the only thing that persists with a mild concussion is the fact the patient has retrograde amnesia. So they don't remember getting knocked out. They don't remember what happened right around the time they got knocked out. But all their other symptoms go away within a really, really quick period of time. Now, in contrast, when somebody has a classic concussion, this is a concussion where the patient takes a shot to the head and becomes unconscious. The unconsciousness is reversible, but the patient continues to have neurological symptoms of some type. So good examples might be like information processing problems, long-term memory problems, those types of things. When we talk about the biggest diffuse closed head injury that we can have, again, we go back to diffuse axonal injury. And with diffuse axonal injury, what we see is that it's caused by shearing of the brain tissue. It's almost like we've taken a blender and shook up the brain tissue, and there are going to be microbleeds all over various parts of the head. Now, when we talk about diffuse axonal injury, you need to know what it looks like, and there's actually several ways that it can present. The CT right above me is a good example of diffuse axonal injury. You can see multiple pockets of bleeding all over the brain. But it's not uncommon in the first couple hours after somebody takes a shot to the head and has diffuse axonal injury for their CT to look completely normal. So when you go out to get somebody in there, they've taken a shot to the head and their level of consciousness is completely depressed and their CT is normal, that can be really, really good, or it can be really, really bad. It could be good because they have a coma or and just a concussion, or it could be really bad because they have diffuse axonal injury. Now, if we spin these patients a second time 24 hours later, most of the time what we'll see is that all that bleeding is now very evident to us. Their whole brain looks just completely whited out, and it almost looks like they have CHF in their head. They've got just massive amounts of fluid all over the place, and their brain looks very, very white. Okay, when we talk about skull fractures, just a quick review of a couple of different types of skull fractures. Linear fractures are a fracture that's just a solid line. So like if somebody was to hit you in the head and it just created one crack, that's a linear fracture. Linear stellate fractures are when we have one central point of impact with multiple fractures radiating out in various directions. So you know what a starred windshield looks like. A lot of times a linear stellate fracture looks very similar. You've got this central point of impact with multiple cracks radiating out all different ways. When we talk about diastatic fractures are where we have physical movement of the suture lines and gross deformity of the head. A lot of times you'll see this like in people who have had their head run over or something like that. It's just a massive, massive blow or a massive pushing or crushing type injury that causes parts of the skull to completely displace. When we talk about depressed skull fractures, we know that's when we actually have a piece of skull that's actually pushed down into the brain tissue itself. And so a good example of that would be like something that we might see with being hit with a hammer, or if somebody was to take a shot to the head with something that's relatively small but has a massive velocity. We'll also see a lot of depressed skull fractures with things like gunshot wounds to the head, things like that. Now, when we talk about basilar skull fractures, remember that basilar skull fractures are fractures that occur in the actual base of the skull itself. And the big thing to remember about basilar skull fractures is that most of the time the way we diagnose them is not radiographically, but rather it's clinically, it's in our assessment. The two classic things we see with basilar skull fractures are the patient may have battle signs, which we'll recall as bruising behind the ears, or they may have raccoon's eyes, which is bruising around their eyes. Remember with basilar skull fractures, if they've got rupture rupture of the meninges as well. They may have bleeding out of their ears, or they may have bleeding out of their nose. And one of the things that we want to do if we see blood coming from the ears or the nose is we want to assess whether or not there's actually cerebral spinal fluid in it, which would confirm the diagnosis of a basilar skull fracture. Now, the way that we do that, there's two different ways that we can do that. The classic thing we always teach people is if you take like a gauze sponge and put it up against the bleeding, you'll see that as the blood comes in contact with the gauze, the CSF will separate out and it creates like a bullseye type pattern. That's one way that we may assess whether or not somebody's got CSF. The other way is actually to do a dextro stick on the blood that is draining from the nose or the ears. If we see a dramatic change in the blood sugar between a capillary blood glucose level, say that we take from the finger, and the glucose level that we see in the blood that's coming from the nose or the ears, that's pretty much diagnostic for being CSF, because CSF has a very large amount of glucose in it. So again, if you poke somebody's finger and they've got a serum glucose of 120, and you dextro strip their nose and you see that the blood coming out of their nose has a blood glucose of say 160, 170, 180, that's probably got CSF in it, and the patient's probably got a basilar skull fracture. Okay, when we talk about management of basilar skull fractures, probably the biggest thing that we need to remind ourselves is that we don't want to stick anything in their nose. This is a picture right here of a bad situation. This gentleman obviously has a basilar skull fracture, as evidenced by the fact that he's got profound raccoon's eyes, but yet he's got a NG tube sticking in his nose. There's lots and lots of pictures out there. This is a picture right here that was taken of somebody who had an NG tube stuffed up in their head because of a basilar skull fracture. Here is another picture. The picture on the upper screen is just a side x-ray. The picture on the lower screen is a slice CT showing an NG tube wrapped up in the brain. And here are some more pictures of NG tubes stuffed in various parts of the brain because they were placed in patients who had basilar skull fractures. Now, NG tubes are not the only thing that can be pushed up in the brain. These are all various pictures of ET tubes that have been pushed up in the brain, so we also want to avoid things like nasal intubation and things like that. Okay, when we talk about the common complications we see with skull fractures, there's several things we need to be concerned about. The first one, obviously, that we need to be concerned about is intracranial infection. Almost always, when somebody has an open skull fracture, they're going to get a profound infection, and that profound infection causes brain swelling, and that secondary insult in and of itself can be enough to do someone in, so we want to keep the wound as clean as we can. Obviously, if somebody's got a skull fracture, if it was a significant enough blow that it could cause the skull to fracture, there's going to be some level of bleeding underneath it. So we need to be cognizant of the potential for hematomas, and those hematomas to increase in size and increase ICP. Obviously, we're going to be worried about the brain tissue underneath. If we're going to be transporting this patient by air, we want to be worried about any air that's in the skull. If the patient has pneumocephalus, we know that as we take that patient up to altitude, that air is going to expand, and that in and of itself could cause decompensation. And then obviously we want to be concerned about nerve damage underneath as well. Okay, now let's talk about spinal cord syndromes. There's 3 different types of spinal cord syndromes that you need to be aware of. All 3 of them are pretty rare, so that's one of the reasons why they probably love to ask you about them on standardized exams like the FPC, the CFRN, the CTRN, or the CCRN. So first we'll talk about a Brown's cord syndrome. So if this was my spinal cord right here, this circle, a Brown's cord syndrome would be if I had a hemisection of the cord where it's been cut only halfway on the lateral side of the cord. So when we talk about Brown's cord syndromes, the classic presentation for this type of patient is it's the patient who presents with neurologic symptoms of different types on different sides of the body. The way I always remember Brown's cord syndrome is I always remember 2 parts of the body, 2 sets of neurologic symptoms, and it's a 2-word cord syndrome, Brown's cord. So when we talk about the presentation, on the side where the injury is, you'll see that they've lost their ability to move, they've lost their vibratory sense, but they've maintained their ability to feel temperature and their ability to feel pain. In contrast, on the other side of the body, they still have the ability to move, they still have the ability to feel vibration, but they don't feel pain and they don't feel temperature. So 2 very different sets of neurologic symptoms on opposite sides of the body. When we talk about central cord syndrome would be if I lost the middle lumen of my cord. And so usually when we see central cord syndrome, we see that with like an arterial embolism in one of the spinal cord arteries. And when we lose the central part of the cord, that little part in the middle, then what we see is the patient has greater motor weakness in their upper extremities than in their lower extremities. And so they present exactly opposite of what we're used to looking at when we look at somebody who's got a spinal cord injury. Usually if there's a transection, what we anticipate is that everything above the transection is going to be fine, i.e. like I can move my fingers and my hands, but my legs would be paralyzed. With central cord syndrome, it's the exact opposite. I've got significant weakness or deficits in my upper extremities, but yet my lower extremities, my legs, are fine. Finally, the last cord syndrome that you need to know about is anterior cord syndrome. When somebody has anterior cord syndrome, they have complete motor pain and temperature loss below the lesion, but yet they can still feel vibration, they can still feel touch, and they still have proprioception or proprioception, which, as you recall, is knowing where your body is in space. In other words, knowing your hand is here as opposed to here. So with anterior cord syndrome, again, they've lost motor control, they've lost pain, they've lost temperature, but they still have proprioception, they still have vibratory sense, and they can still feel touch. Okay, some other things to be aware of. Just a quick note about spinal cord injury without radiographic abnormality. Remember that especially in children, just because somebody has a normal C-spine series does not mean that they don't have a cord injury. A lot of times patients with cord injuries will have, or not a lot of times, but occasionally, patients with cord injuries will have a completely normal C-spine series on X-ray despite the fact that there's a pretty significant damage to their cord. And again, this is much more common in children than anywhere else. Now, just two terminology things that you need to know about. You need to know about spinal shock and neurogenic shock. Remember when we talk about spinal shock is caused by swelling, and spinal shock is the areflexia with flaccid paralysis that comes right after an injury. So just because somebody has got paralysis at the time of an injury does not necessarily mean that they're going to stay paralyzed. A lot of times this spinal shock phenomenon, as the swelling goes away, the patient will regain neurologic function. Now, when we talk about neurogenic shock, here we're talking about the hemodynamic effects that come with a spinal cord injury. And remember, the classic presentation with neurogenic shock is that wherever the cord has been cut, everything below that is going to be parasympathetic dominant. So everything above the injury is going to be pale and cold. Everything below the injury is going to be massively vasodilated, so thus it's going to be red and flushed. The other classic things we see with neurogenic shock is the patient is hypotensive, but yet is not tachycardic. That is the classic thing for neurogenic shock. The hypotensive trauma patient who is not tachycardic. And remember that when we're talking about tachycardia, we're talking about tachycardia relative to the patient's clinical condition. So if you've got somebody who's got a blood pressure of, say, 70 systolic, but yet their heart rate's only 80, I would argue to you that that is absolutely positively a relative bradycardia, because if your systolic blood pressure is 70, your heart rate should be like 130, 140, 150. So we're always thinking about the bradycardia relative to the patient's condition. Okay, last but not least, when we're talking about management of neurologic patients, you need to know what autonomic dysreflexia is. Autonomic dysreflexia is when a patient has a massive sympathetic response in response to some kind of noxious stimuli, but yet they have paralysis in the area where the stimuli is occurring, so they can't feel it. So a classic example of this is like somebody who's got a spinal cord injury that has paralyzed them from the waist down, and they've got a Foley in place that's straining their bladder, but the Foley becomes clamped, and so their bladder no longer has the ability to drain, so it starts to get bigger and bigger and bigger. Well, because of the fact that they have no feeling below their waist, they can't feel that discomfort, they can't feel that pain, but yet their body may still produce this massive sympathetic response we call autonomic dysreflexia. So they may become tachycardic, they may become hypertensive, and autonomic dysreflexia can be very dramatic. The patients can have hypertension that goes up to the point where it causes the patient to have a CVA, where they have an MI, they have retinal seizures, or excuse me, retinal hemorrhages, they have seizures. So autonomic dysreflexia can be a fairly big problem. When we talk about treating autonomic dysreflexia, the big thing you want to do is see if you can identify what the noxious stimuli is that's making your patient appear very sympathetic, and see if you can try and get rid of it. Sometimes we can't get rid of it, and in those cases what we need to do is we need to treat the symptomology. A lot of times we'll treat the hypertension with vasodilators, we'll treat the tachycardia with beta blockers, so on and so forth. Now again, we said one of the more common places where this occurs is in patients who have had overdistension of their bladder. If you have a patient who becomes autonomic dysreflexic because of overdistension of their bladder, a lot of times those patients have sequestered a significant amount of fluid. It's not uncommon for them to have like 2 or 3 liters of fluid in their bladder. So if you identify that that's what the problem is, say the Foley has become clamped, or the patient didn't have a Foley and you just put one in, make sure that you drain the bladder slowly. Remember, we don't want to just let it completely drain out if there's 2 or 3 liters of urine there, because if we just immediately drain it in a very rapid fashion, the patient's going to have massive fluid and electrolyte shifts. The patient's going to have the patient may become bradycardic and hypotensive because of vagal stimulation. So there's several not good things that can happen associated with that. So we want to make sure that we drain their Foley slowly. Okay, now when we talk about cerebrovascular accidents, just a quick review. Remember that there's 3 kinds of strokes. We have embolic strokes, hemorrhagic strokes, and thrombotic strokes. Remember that when we talk about an embolic stroke, an embolus is something from the outside typically. So a good example of an embolic stroke would be somebody who has an occlusion of a blood vessel because of some external piece of hardware that was allowed to float around in their bloodstream. Like, that's why we're teaching people to put in IVs. We always teach them to be very careful about not shearing the ends off their catheters. If a tip of a catheter was to occlude a cerebral artery, then that would be a good example of an embolic stroke. We know that hemorrhagic strokes are where we have rupture or tearing of a blood vessel, and obviously the patient starts to bleed into the brain tissue itself. And finally, when we talk about thrombotic strokes are caused by blood clots, and those are probably one of our more common types of cerebral vascular accidents. Now, regardless of whether the stroke is embolic, hemorrhagic, or thrombotic, the big things we want to do, we want to make sure that we prevent additional insult. We want to make sure that we maximize cerebral blood flow. We want to control increases in ICP, and we want to manage the associated conditions, making sure we protect their airway, making sure we protect their hemodynamic status, all that good stuff. Now, if the patient has malignant hypertension, kind of the consensus on literature as it stands now is usually if the patient has a systolic blood pressure greater than about 180 over a diastolic blood pressure greater than 110, we should consider lowering that some with vasodilators. The big word here is consider, and that's a hotly debated topic because there are some who believe that when the blood pressure gets that high, it just adds to the loss of autoregulation of the brain's perfusion, and there are others who argue that the whole reason that the patient is that high is because they're trying to overcome an increase in ICP in order to maintain an adequate CPP. The reality is that right now we just don't know. It's hotly debated on both sides. So if the blood pressure is greater than 180 over 110, we should consider, and I'll leave it at that, consider lowering the blood pressure. The one place where consider goes out the window is if the patient is going to get fibrinolytics. If this is a thrombotic stroke that we're going to treat by giving the patient TPA, then we definitely need to lower the blood pressure if it's greater than 180 over 110, because if it is higher than that, it dramatically increases the chance that the patient is going to develop a bleed. One of the things that we would like to do fairly on is get an NIHSS score. That will help the neurologist with his assessment and his later decision making. And obviously, if it is not a bleeding type stroke, i.e. if it's not a hemorrhagic stroke, then we want to go through our criteria and figure out if the patient is a candidate for fibrinolytics. Okay, when we talk about reperfusion, there's 3 ways that we can perfuse the brain. First, we'll talk about TPA, and when we talk about TPA, there's 2 ways we can give it. By and far, the most common way that we give TPA is IV or intravenous. Remember, your criteria to give IV TPA is that the stroke has to be less than 3 hours old, and the patient has to have no fibrinolytic exclusion criteria. When we talk about the 3-hour window, remember that 3 hours has to be documented. So, for instance, if somebody woke up with stroke-like symptoms 45 minutes ago, that patient is not a candidate for IV TPA because we cannot document the window. So we have to know exactly when the symptoms started. When we talk about intra-arterial TPA, that's kind of the next step that's available to us if we can get the patient to a neurointerventional radiologist. If we can get them to a neurointerventional radiologist within 6 hours, again within 6 hours, then the neurointerventionalist may be able to give the patient IA TPA by advancing a catheter up through the arterial system and actually putting TPA right up against the clot itself. Obviously, that's done by under fluoro in the radiographic suite. Now finally, if the patient is not a candidate for IV TPA or IA TPA, we have one last choice that we may be able to do to save a patient from permanent neurologic damage, and that is actually something called a MERCI procedure. MERCI stands for Mechanical Embolus Removal and Cerebral Ischemia, and if you look at the pictures above me, that actually shows you what the MERCI device looks like, and again, this is done by a neurointerventionalist in a radiology suite. They would actually take the patient under fluoro and advance this guide wire looking thing or spring looking thing up into the clot, and they actually try and wrap the clot up in the spring and then pull the clot out. Now, the big thing that's advantageous about the MERCI procedure is that we can do that in patients for up to 12 hours. There have been multiple cases where patients have had a MERCI procedure done at the 12-hour mark, and those patients have had a complete total neurologic recovery. So very, very impressive stuff. Okay, when we talk about coma, remember there's lots and lots of reasons for coma. One of the great ways to remember all your different things that can cause coma would be the acronym unconscious. When we talk about unconscious, the U is for units of insulin, so obviously is the patient hypoglycemic or hyperglycemic. The N is for narcotics or drugs. C for convulsions or seizures. O2 for oxygen, i.e. is the patient hypoxic? Does the patient have any of those different types of hypoxia that we've talked about in other places? Does the patient have a non-organic reason for their seizure or a psychogenic reason, i.e. is the patient feigning coma, or does the patient have a psychological reason for why they're acting as if they're in a comatose state? The S would be for stroke. Our second C would be for cocktails or alcohol. ICP obviously will cause coma and increase in the ICP. Organisms like infectious organisms that would cause either encephalitis or something like that can cause a comatose state. Urea can cause a comatose state, either hepatic or renal failure, and finally shock can cause a comatose state. So when you have somebody who's got an unknown etiologic coma, that unconscious acronym can help us run through reasons why they would be unconscious. When we talk about the treatment for those patients, obviously it's supportive. ABCs protect their airway. Remember, if the patient doesn't have a conscious ability to swallow, by definition they have an unstable airway and it needs to be protected. Remember that if you have a patient who's comatose and you don't know why, one of the things we need to critically evaluate for is any potential for trauma, and if the patient's a trauma patient, they need to be spinally immobilized. And when we talk about the pharmacologic management of coma, we all know that the coma cocktail is the 3 drugs Narcan, dextrose, and thiamine. Remember, we give the Narcan in case of the fact the patient has a narcotic overdose. We give dextrose if the patient's got a documented hypoglycemia. And finally, if you give dextrose, you also need to give thiamine so that you prevent Wernicke's encephalopathy. When we talk about diagnostic management for these patients, if the above things haven't worked, then obviously we need to spin their head. We need to get a CBC and a Chem7. We'd like to get a urinalysis and a tox screen, and it'd also be helpful to get an ABG as we start working down our unconscious acronym, trying to figure out what's wrong with this person. Okay, when we talk about epilepsy and seizures, just a quick review of the typical presentation of a seizure. Remember that there's usually 4 phases to a seizure. The first phase is the aura. A lot of times people feel like something's wrong, and a lot of times it's hard to describe what that is, but they just don't feel like something is right. The next thing that happens is they go into a tonic phase. The tonic phase is characterized by muscular extension. That's where the patient becomes very, very rigid, and that's followed by a clonic phase, which is where we have the alternation between being relaxed and being stiff, or where we see the typical seizure type activity that people classically think of when they think of a seizure. Finally, we'll have a postictal phase where we'll have a slow return to a normal level of consciousness. Now, when we talk about the treatment for those patients, obviously the first thing we want to do is protect their ABCs, protect them to make sure they don't have injuries if they're actively seizing. We want to think about etiologies, and we want to stop the seizure activity if it goes on for any length of time. When we talk about the treatment for seizures, We've basically got 4 pharmacologic ways that we can manage seizures. The first thing that we can do for these patients is we can put them on benzodiazepines, so we can use things like Ativan, Versed, or Valium to stop seizures. Those are our first-line drugs because they work the quickest and they're the most reliable. If that doesn't work, then the next drugs that we usually hop to are phenytoin or fosphenytoin, which is Cerebex. And our next step up, if those drugs don't work, is to go to barbiturates. And remember that when you're giving somebody barbiturates for seizure, you're basically putting them into a barbiturate coma. So you're putting them into a very deep stage of sedation. And finally, if we've tried benzos, we've tried Dilantin or fosphenytoin, we've tried barbiturates, and the patient continues to seize despite all of our interventions, there comes a point, I can't say exactly when that is, but there'll come a point where we need to start thinking about the fact that this constant massive increase in sympathetic tone that's occurring with all this seizing activity, this increase in metabolism, is going to put the patient in lactic acidosis. It's going to cause muscle breakdown. That can cause rhabdo. And at that point, when we're at the point where the patient's been seizing so long, we're concerned about those types of things. If nothing else has stopped it, then we may consider neuromuscular blockers in the attempt to actually paralyze the patient. Again, most of the time we don't like to give paralytics to patients who are seizing, especially if it's a relatively simple seizure that we've stopped with benzos, barbiturates, or fosphenytoin, because we would prefer to keep those patients not paralyzed so that we can see if they start to seize again. But if a patient is just in sustained seizures that you can't break with any of those other things, then you're kind of left with no choice. Okay, some neuromuscular diseases you need to know a little bit about. You need to know what Guillain-Barré syndrome is. And when we talk about Guillain-Barré syndrome, this is where patients have demyelination of the axon, and it causes a progressive ascending muscular weakness. So the patients actually become weak typically in their hands first or their feet first, and it tends to move up their body. When we talk about what causes Guillain-Barré, there's some arguments out there about what causes it, but it's probably an autoimmune disease. When we talk about the presentation for these patients, a lot of times it's distal weakness and numbness and tingling that starts to move up towards the core, and that can be relatively long or it can be very short. So what I mean by that is you may have a patient who starts to develop these symptoms a week before they end up with profound symptoms, or it may be an hour before they end up with profound symptoms. When we talk about the incidence of Guillain-Barré, it happens much more often in females than in males. There's like a 5-to-1 ratio. The classic things that we see in these patients from a physical assessment point of view, a lot of times they've got a lack of DTRs, and when we start working them up as an unknown neurologic patient, we'll go and get a tap of their spine, and a lot of times what we see is that they've got really high levels of protein in their CSF. When we talk about the treatment for these patients, it's basically symptomatic. You want to protect their airway. If the patient doesn't have the ability to effectively ventilate anymore, then you want to take over their ventilation with mechanical ventilation, and we would use all of our standard ACLS drugs if necessary. Now, when we talk about myasthenia gravis, this is actually a very different disease. Myasthenia gravis is also thought to be autoimmune, and what happens in myasthenia gravis is the patient has antibodies formed that block the acetylcholine receptors. So when acetylcholine receptors are expecting to be stimulated by acetylcholine, that doesn't happen because they've been blocked by antibodies that the patient has formed. When we talk about the presentation for these patients, the early thing that people often present with myasthenia gravis is actually inability to control their eyelids. A lot of times their eyes look very sunken, and their presentation tends to increase in intensity over their face. So the next thing we see after the eyelids is we see that the rest of the face becomes very weak. Next, they'll lose control of their head and their neck. And then these patients can progress to the point where they lose control of their respiratory system. Now, the big thing to remember about myasthenia gravis is we actually give these patients cholinergic drugs to treat it. And the cholinergic drugs in and of themselves can cause something called cholinergic crisis. And cholinergic crisis presents exactly the same, or often exactly the same, as myasthenia gravis. Now, when we talk about treatment for these patients, just like anybody else with neuromuscular suppression, the big thing we want to do is protect their airway. A lot of times these patients, we can adequately assist them by putting them on BiPAP, but if that doesn't work, then we need to go to intubation. Remember that the pathophysiology of this disease is that autoimmune substances are blocking cholinergic receptors. So obviously the last thing we would want to do for this patient is give them succinylcholine. That's not going to do us any good, and we would prefer to stay away from that. So we don't use Sux in people with myasthenia gravis. When we talk about differentiating myasthenia gravis from cholinergic crisis, the drug we use is something called Tensilon. Now again, if the patient's got a history of myasthenia gravis, they're probably going to be on cholinergic drugs, and if they present with these symptoms, the million-dollar question is, okay, well, is this an exacerbation of their myasthenia gravis, or is the patient in a cholinergic crisis because of the drugs we're giving them for their myasthenia gravis? And again, the way we tell is we give them Tensilon. If the patient is having a myasthenia gravis crisis, when we give them the Tensilon, almost immediately they resolve. Their symptoms go away. In contrast, if the patient is having a cholinergic crisis when we give them Tensilon, actually we're going to see an increase in all that cholinergic symptomology, and we go back to sludge, all those things that we talk about when we talk about organophosphates. So their cholinergic crisis, they're going to have salivation and lacrimation and urination and defecation and GI stuff and all that good stuff. So again, the way we diagnose this in somebody who's got a known history of myasthenia gravis is we give them Tensilon. If they get better, we knew that it was the myasthenia gravis that was exacerbating itself. If they get worse or if they don't improve, we know that it's a cholinergic crisis because of their medications. Okay, when we talk about acute meningitis, remember that acute meningitis is an inflammation of the meninges themselves. Remember that when we talk about acute meningitis, it's almost always bacterial. It's pretty rare that acute meningitis is anything else but bacterial. Now, when we talk about acute meningitis, remember the physiology behind this is that infectious agents compromise the blood-brain barrier, and thus the patient gets cerebral edema. When we talk about the presentation for these patients, the big way they present is a lot of times complaining of a headache and neck rigidity or nuchal rigidity. A lot of times they'll have photophobia, and the other thing that we may see in acute meningitis is level of consciousness changes, including seizures. Some other things that we may see, the patient may present with fever and chills just like anybody else with a bacterial infection. They may be vomiting because of an increase in ICP, and a lot of times they'll actually have a co-contaminant upper respiratory infection. Remember that two signs we look for in meningitis are Kernig sign and Brudzinski sign, and those signs relate to movement of the head and movement of the legs. Remember that if we move the head down, we expect that they're going to bring their legs up. If we bring their legs up, we expect that they're going to bring their head up. So it's almost like their head and their legs have to come together. Those are Kernig and Brudzinski signs, and those are classic of meningeal irritation. Now, when we are looking at acute meningitis, remember we said the first thing we need to do is we need to assure that this is not a epidural bleed, or excuse me, not an epidural bleed, a subarachnoid bleed. We want to make sure that first, and the way that we do that is we spin their head to make sure they don't have a subarachnoid bleed. If they don't have a subarachnoid bleed, then the way we diagnose meningitis is we actually do a spinal tap. And when we do a spinal tap, depending on what we see in the glucose, will give us a lot of information about whether or not they have meningitis. Now, if it is viral meningitis, typically what we'll see is the patient will have no glucose, and their glucose will be relatively normal, and their protein will be just a little bit high. So again, if it's a viral meningitis, which again is very rare, what you'll see is the patient's glucose is normal and their protein is slightly elevated. In contrast, if their meningitis is bacterial, which is what we see most of the time, remember that patient's spinal fluid, their glucose is going to be very, very low, and their protein is going to be very, very high. So I'll say that again. The classic presentation of bacterial meningitis when we look at the CSF is that the glucose is low and the protein is very high. Okay, when we talk about the treatment for these patients, remember that if it's acute meningitis, the standard is droplet precaution, so we need to make sure that we've got a mask and gown and all that good stuff on. We want to manage their ABCs, make sure they're fluid resuscitated. Oftentimes they're septic and do need fluid. Some other things we want to do, remember we said we would do a CT first to make sure they didn't have a subarachnoid bleed, and we would follow that with an LP. Once we've got the LP done, or we want to get our antibiotics on board. And so when we talk about antibiotics, kind of the consensus in the literature as things stand now is we usually start these patients off with the cephalosporin and we add vancomycin to that. Remember, with acute meningitis, you want to be watching for the syndrome of inappropriate antidiuretic hormone, or SIADH. occurs very often with meningitis. We also want to watch for hydrocephalus and increases in the ICP. And if they've got an increase in their ICP, we're going to manage them just like we would manage any other traumatic brain injury. And finally, one of the things that we do tend to do in acute meningitis that we don't do in head injuries anymore is we still do tend to use steroids, and the steroid that we most commonly use is dexamethasone. Okay, when we talk about encephalitis is when we actually have an infection of the brain itself. Oftentimes it coexists with meningitis, so a lot of times it presents exactly like meningitis. Unlike meningitis, which is mostly bacterial, encephalitis is usually viral. When we talk about the most common types of viruses that cause encephalitis, the most common viruses are herpes and varicella zoster. Those are the most common reasons for encephalitis. And when we talk about the presentation, again, it may be just like meningitis. Oftentimes the patient presents with fever, headache, and nausea and vomiting. Patient acts like somebody who's got an increase in their ICP. If they've also got meningitis, they may have nuchal rigidity. A lot of times they may have a rash, and that's a lot of times what will help us separate whether it's meningitis or encephalitis, whether or not the patient has a rash. The patient may have changes in their level of consciousness, and again, the thing we're going to do for these patients is we're going to do a lumbar puncture. When we talk about the treatment for these patients, the big thing we do is we, again, protect their ABCs, fluid resuscitate them in case they're septic. We usually start these patients on acyclovir if they've got herpes. If the patient's got an increase in their ICP, we're going to monitor their ICP, and we're going to manage it just like we would a traumatic brain injury. And again, you want to watch for SIADH and treat that appropriately. All right, that's all I have for neurologic stuff today. Thank you for being with me. If you have any questions, feel free to email us. My email address is abaca@camanagement.org. That's ABACA@camanagement.org, and I hope you have a great day.
Come for